Welcome everyone to the Society of Thoracic Surgeons Intermacs Updated Adverse Events webinar. Today is Tuesday, November 16th, 2021, little after 11:30 a.m. Central Time, and I appreciate everyone joining. I think we'll go ahead and get started. Carol, thanks for the great music, upbeat, with the blood flowing. So I just wanted to welcome everyone and thank you. And I want to welcome the team from UAB that is with us today. We actually have Patricia Potter, the Quality and Informatics Nurse housed at the Intermacs Data Warehouse, Mr. John Pennington, the Senior Data Manager housed at the Intermacs Data Warehouse, and Dr. Rama Radaruju, who is the Director of Programming at the Intermacs Data Warehouse. And Rama and his team are responsible for the ones that program this great information, which includes Chase Slenderman and Taylor Browser and Brandon and Shakif. So thanks big shout out to the Intermacs Data Warehouse. Thank you so much. And to Patricia and John, thank you. So just wanted to provide some updates. There were a couple of, if some of y'all have noticed, there's a couple of functionality issues with the new updated adverse events. One's on the infection form that we're fixing, correcting, and then we're going to add the early acute right heart failure to the right heart failure form. And those should be, we're testing those right now currently, so they should be live in the database at the end of this week or early next week. So I want to thanks to everyone for just entering some good data into Intermacs. So we'll go ahead and get started. I'll go through the PowerPoint presentation, and just a reminder to any questions that you may have, please ask through the this Q&A function right here and not the chat. If you can ask your questions through Q&A, that'd be great. And I'll go through the PowerPoint, and then we'll take your questions and answers, or take your questions and provide some answers. Let's go ahead and get started. Here's the contact information for myself, Patricia, and then for any operational questions for Intermacs. And we have our resources that we have. If you go to the Intermacs homepage, under the Intermacs appendices, you'll see the user's guide, which is the training manual, the FAQs, the data collection forms, some recorded training sessions, all good things. Quality, it'll tell you how to get the quality of life surveys. So as far as upcoming webinars, we will have a dashboard analytics, a training session in December. I'm working with the Intermacs team to find out a good day and time that works for them. And if you haven't checked out the new dashboard, it is live and in production and fully working, and it's a great resource to the site. So I encourage everyone to attend the training so they can begin using the dashboard. We will not have a users group webinar this month nor December because of the holidays. Our next, we'll have a quarterly reporting webinar January 15th, 2022 at 1:30, and we'll definitely send out reminders for that. So this is an open discussion, as I said, so please use the Q&A function for any questions, and we'll answer as many questions as possible. And we encourage you to ask your questions because we want to hear from you. So we'll get started with these updated adverse events. So if you've noticed, if you've logged into the Intermacs database, we've made some changes with the adverse events. The major adverse events for Intermacs are major infection, major bleeding, neurological dysfunction, and then our device malfunction or device failure adverse event. We have additional adverse events that we made changes to, which includes the hemolysis adverse event, the right heart failure AE, and the renal dysfunction adverse event. Those three now have their own AE form that you will complete. So we'll start off with major infection. There's two categories. If you log on to the major infection form, you'll now categorize these infections as MCS related or non-MCS related. MCS related, an example would be like a percutaneous lead site infection. And an example of the non-MCS related would be like bloodstream infections, a localized non-MCS device infection such as pneumonia or a urinary tract infection or sepsis. And one of the changes that we're making to that major infection form is another change you'll see is when you do enter an infection, it's going to ask you to enter if the bacteria, if it's a bacterial, if it's gram positive or gram negative, and then we give you a short list to choose from of the types of the bacterial infection. And we're working on that now so that you can enter if patient has, to make it a check off as more bacterial types, and if it's gram positive, gram negative, both, or if it's like a bacterial and a fungal infection. So we're working on that to make those changes so you can enter those major infections. Next, we'll go to our major bleeding adverse event. This has been updated to types. We have major bleeding infections, types 1 through 5. Type 1 is your bleeding that's really not actionable, does not cause the patient to seek any unscheduled studies, hospitalization, or treatment by a healthcare professional. So it would be like, I have put as an example your common nosebleed. And I know sometimes these, our patients in Intermacs have major nosebleeds. So this would just be like your easy everyday nosebleed or anything that's the patient really can treat at home and didn't have to receive outside help. Major bleeding type 2, it's an overt actionable sign of hemorrhage, like more bleeding than would be expected for a clinical circumstance. It can include bleeding found by just imaging alone. It does fit the criteria for type 3, 4, or 5, but does meet at least one of the following. So it has to require non-surgical medical intervention in leading to the patient being hospitalized or an increased level of care. So if they were being observed and something that it did prompt them to go to the doctor or the emergency room. The major bleeding type 3, we have 3A and 3B. 3A is overt bleeding accompanied by hemoglobin drop of 3 to less than 5. And obviously the hemoglobin drop must be related to the bleeding event. And then 3B is a hemoglobin drop of 5 or greater. And again, it must be related to the drop in hemoglobin. It must be related to the bleeding event. And then also if they have cardiac tamponade, bleeding requiring surgical intervention for control, excluding dental bleeds, nasal bleeds, any skin bleeding if they have a tear or hemorrhoids, and then bleeding requiring IV vasoactive agents. So all of those would fall under 3B. Our next major bleeding would be type 4. This is your VAD implanted related bleeding. So reoperation after the closure of incision or incisions used to implant the VAD to control the bleeding. And then if the patient's greater than 50 kilograms, if they receive 4 units of packed red blood cells with any 48 hours during the first 7 days post-implant. So if they receive greater than 4 units of packed red blood cells during any 48-hour period during that first 7 days post-implant. And if the chest tube outputs greater than 2 liters within a 24-hour period. We have type 5, which is our fatal bleeding, and we have 5A and 5B. 5A is probable fatal bleeding, no autopsy or imaging confirmation, but clinically suspicious. And then 5B would be your definite fatal bleeding with a confirmation. The next event we're going to look at is going to be our neurological dysfunction adverse event. And these have been broken down into types 1 through 3. Type 1's overt CNS injury, so they're acutely symptomatic brain or spinal cord injury. Your stroke's ischemic stroke with hemorrhage. Type 2 would be covert CNS injury, so they're acutely asymptomatic brain or spinal cord injury detected by neuroimaging. And then your type 3 would be your neurological dysfunction, acutely symptomatic without your CNS injury. So your TIA and deliriums would fall under the type 3. And then we have our device malfunction. We have our device failure. We have a major device malfunction, AE, and a minor. So for the minor device malfunction, just for it to be a major device malfunction, it must have cause impending harm to the patient or death. And just a note for the minor device malfunction, if the external controller is done in an inpatient setting just because it's for logistical reasons in a stable patient, it will be considered a minor device malfunction rather than major. So we would consider replacement of the controller done in an inpatient setting in a stable patient. It would be considered a minor device malfunction. It's not a major. And so we'll move on to hemolysis. Hemolysis is now an entered event. In the past, 7 years, I believe it's been a triggered event. But now all things come full circle. So now we've gone back to where the sites, you can enter your own hemolysis events. You'll see reminders on those follow-up forms that if the patient's, if the patient's had a hemolysis event, to enter the form. We have major and minor hemolysis. So major hemolysis is a plasma-free hemoglobin value greater than 20 milligrams per deciliter or a serum LDH level greater than 2.5 times the upper limits of the normal range at the implanting site, occurring after the first 72 hours post-implant and associated with clinical symptoms or findings of hemolysis or pump malfunction. And when you complete these forms, you'll still have your physical findings, and you will have to still enter your lab values for hemoglobin, LDH, and then hematocrit or hemoglobin. It will be your choice. Again, major hemolysis occurs after the first 72 hours post-implant and is associated with clinical symptoms or findings of hemolysis or pump malfunction, which means the minor hemolysis is the plasma-free hemoglobin value greater than 20 milligrams per deciliter or a serum LDH level greater than 2.5 times the upper limits of the normal range at the implanting site, occurring after the first 72 hours, but it's the absence of clinical symptoms or findings of hemolysis or pump malfunction. So remember, minor is you still have the lab values that make it a hemolysis event, and it's still after the first 72 hours post-implant, but the patient is not exhibiting signs or symptoms of hemolysis or pump malfunction. You see it in the labs. That's for minor. Our next adverse event we'll look at is the right heart failure event. And again, the right heart failure event has moved from a triggered event, meaning the database would assign a right heart failure event to your patient, label it if it had met the algorithm that was programmed in the database. So again, things come full circle, and so now sites are able to enter their own right heart failure events. We have early acute right heart failure, early post-implant right heart failure, and then late right heart failure. And right heart failure, again, has its own form for you to complete these events on. The early acute right heart failure is the need for implantation of a temporary or durable RVAD, including ECMO, concomitant with the LVAD implantation. So the RVAD's implanted before the patient leaves the operating room. So this would be your early acute right heart failure, is if they leave the OR with a BiVAD for that procedure. Our early post-implant right heart failure is the need for implantation of a temporary or durable RVAD, including ECMO, within 30 days following the LVAD implantation for any duration, or the failure to wean from inotropic or vasopressor support or inhaled nitric oxide within 14 days following LVAD implantation, or having to initiate support within 30 days. So they'll have to be on those. You're not able to wean the patients from inotropes or the vasopressor support or the inhaled nitrous within 14 days following that LVAD implant, or you have to initiate those 3 supports within 30 days of the implant. And then you must have 2 clinical findings and 1 manifestation from the criteria listed on the right heart failure form. And that's pretty straightforward. When you go to the form, it'll list the clinical findings and the manifestations. Our next is the late right heart failure. We have the RVAD implantation, including ECMO. So the late's just greater than 30 days after the LVAD implant. This may occur within the index hospitalization, so that it may occur within the primary LVAD implant or during a subsequent rehospitalization for any diagnosis which results in the need for a temporary or permanent RVAD. So it may occur again. It's greater than 30 days. It could still be the patient still hospitalized. They weren't able to be discharged for that primary LVAD implant, or if you had to readmit them for a reason and then realized that they needed an RVAD. So as long as it's greater than 30 days after an LVAD implant, it would be considered late right heart failure. And then hospitalization that occurs 30 days post-implant, which requires IV diuretics or inotropic support for at least 72 hours and is associated with 2 clinical findings and 1 manifestations. So the late right heart failure clinical findings, these are the clinical findings for the late right heart failure. You must have 2 of these clinical findings: the ascites, the functional limiting peripheral edema, which would be greater than 2+, elevated estimated JVP at least halfway up the neck, and if your patient can get upright, and then an elevated CVP, which would be considered greater than 16. And then they must have 1 of these manifestations. The renal serum creatinine is greater than 2 times the baseline, the liver injury with an elevation of at least 2 times the upper limit of normal of your AST, ALT, or the total Billy's greater than 2.0. Your pump flows reductions greater than 30% from baseline in the absence of tamponade, or SVO2 is less than 50%. And then your cardiac index is less than 2.2 liters, and your the lactate's elevated greater than 3.0. So to be late right heart failure, they must meet 1 of these manifestations and 2 of those clinical findings. Our next adverse event we're going to review is the renal dysfunction. We have acute versus chronic for the renal dysfunction. So acute is broken down into 3 stages, which if you've logged on to the renal dysfunction form, you'll see it's varying serum creatinine levels and urine output. So you'll just have to look at those varying levels of both of those and check which one's applicable. And then the stage 3 is renal replacement therapy, which includes dialysis or ultrafiltration. Our chronic renal dysfunction, it's an increase in the serum creatinine of 2 milligrams per deciliter or greater above the baseline or the requirement for renal replacement. which could be dialysis or ultrafiltration, either of which is sustained for at least 90 days. So basically, the chronic renal dysfunction must have been occurring for at least 90 days to be labeled a chronic renal dysfunction adverse event. That's our review of the adverse events of the changes. There is also the association classification, which you'll see on all the AE forms. You'll classify these adverse events. Were they patient-related, which would be non-adherence to medical therapy, management-related, which would be medication management or medical treatment-related issues, and then device-related, if the device is the issues resulting in the adverse event. And usually your team or you, it'll be known if it's how to classify the association of the adverse event, whether it was patient-related, management-related, or device-related. So I do want to thank everyone. Thank you again for joining the adverse event webinar. I think now we have a few questions, so we'll go ahead and go through those.
Catherine, I can take the first few if you'd like.
Okay, sure.
Okay. So the first question is, I wanted to ask for a reminder on how to appropriately capture a patient scenario with multiple RVAD ECMO conversions. Patient went into VAD implant with VV ECMO, so captured LVAD implant only. That's correct. We don't capture the ECMO piece, so on the VAD implant, it would be an LVAD only. The second piece of this is the oxygenator was removed, so now RVAD only 5 days later, so I added the RVAD as a device. Is that correct? Yes, that is correct. And then the last piece is the oxygenator added back 10 days later. How should I capture an Intermacs? So once the oxygenator is put back and it's now functioning as ECMO, you would explant the RVAD. And then Minnie's next question. Also, when did you say the next dashboard training event? When did you say the next dashboard training event was going to be, or if that was recorded, could you please share the link? So the next dashboard meeting is going to be sometime or dashboard webinar will be in December, correct, Catherine? You're just finalizing the.
Yeah, correct.
And then, Minnie, I can send you all of our webinars are recorded, so I can send you the YouTube link if you would like, and you can view the previous one from there. Next question. Will there be an update to the Manual of Operations and Procedures version 4.0 to include the specifics of the change in the AE definitions? So under the Intermacs appendices on the UAB website, if you go to Intermacs appendices under Appendix A, the new adverse event definitions are there. And then under Appendix M, the user's guide has been updated to include those. And under Appendix P, all the forms are listed there as well. And you can click on those to see the newly updated AE forms. Also, like I had said, that on the YouTube website, all the recordings are there if you ever wanted to reference back some of these webinars, just to go over, what we just talked about. And then the next question, hello, I'm hoping you can share the decision to change the AE from being auto-generated to self-reporting. It seems we are set up to potentially undercode, at least our abstraction time will increase. So yes, indeed, that was a conversation we talked about. We hoped it wouldn't include too much extra time. We are now only collecting them on the AE forms, so it's not like you have to enter like your LDHs and hematocrits on the follow-up form, and then we're asking you to enter them again on the AE. It's just still entering them in one place. One of the nice things about it is that if you do have, abnormal lab draw or an abnormal value, it does allow for you to enter the AE if it truly was right heart failure or a hemolysis event, and it won't just take what you enter from the follow-up. I don't know, Catherine, if you want to speak more to, going from the zones to.
Yeah, sure. I know, Cindy, and thank you for your question. We did, we did discuss this at length. I think actually the thought was, we actually had a lot of feedback. The sites really wanted to be able to report the events as they occurred. Instead, we really were capturing the more of, instead of the incidence of it, really the prevalence of it, because we captured it, during those time periods, like from 3 months to 6 months and so forth. So I think we actually were, the task force really had thoughts that we really were not capturing all of them accurately. And since especially the right heart failure and hemolysis are important to this patient population, we wanted to make sure that we were capturing all the events as they occurred. I understand that it does seem like, it is more time consuming, but as Patricia said, you don't have to enter that on like every form. You just enter on every follow-up, you just enter it as it occurs now. And just a reminder, and I believe Patricia hit on this also, but I'll say it again. You can choose your peak plasma-free hemoglobin or LDH. You do not have to enter both of those, but you can. And same for the max and min of the hematocrit or hemoglobin. You don't have to enter all 4 of those fields. You could just pick a hemoglobin or a hematocrit. It's whatever you're choosing you like. So yeah, but thank you, Cindy. We appreciate that.
Okay. The next question, hello. Are type 1 and type 2 major bleeding events ones that only need to be reported while the patient is inpatient, or are we to report them anytime the patient experienced them, regardless of inpatient or outpatient setting? So the type 1 is exactly that. The patient did not have to seek any medical treatment. They didn't need to go to clinic. They didn't need to come to the emergency room. It's just they had a bleeding episode, and hopefully that will be reported at the follow-up that, something happened. They had a very minor bleed that was able to be managed at home.
Yeah, thank you. And we did, Sierra, we did add the AE reminders on all the follow-up forms now. So we went back to that to kind of give you a reminder of, oh yes, be sure and add all the events. So hopefully we'll get those events captured.
Okay, and then the next question, what is the link to be able to access this presentation in the future? So I put in the chat box, it's the website to the YouTube where all the webinars for the dashboard, the AE user group webinars, everything that's been recorded for Intermacs is on there. So you'll be able to see this presentation, the previous one, and the dashboard webinar as well, if you ever wanted to reference it back. And then the next one from Tiandra, how do you capture a change from VA ECMO to VV ECMO during initial implant? So we don't capture the ECMO piece in Intermacs.
Patricia?
Yes.
I believe yes, that it is correct. We don't, I know in the definition it does say including ECMO. So I know that you can, on the implant form, there is, a section, a box you can check under the concomitant surgeries if an ECMO was started.
But can you
from VA to VV? That I'll have to look, but I don't think it'll allow you to capture that change from VA to VV. You're correct. It just says if ECMO is initiated.
I was gonna say, I can take a look too and see exactly what it says on the form.
Okay, let's let her look. I'm kind of thinking we did change that with the implant form, but let's just verify. And I'll take the next one while you're looking that up, Patricia. How will the structure of the quarterly reports change if the new changes to the data definitions? And when will we see the new definitions reflected? I know the structure, I believe, will stay the same. And John or Rama, if you can add to that, that would be great. Actually, Dr. Ryan Cantor is the director of reporting, and I don't believe he's on the webinar today. He could speak to that. But Rama or John, or Patricia, if you can add to that, that would be great.
This is John. I can jump in. So the last time we talked about this stuff in a group setting, I asked Ryan about that. The reports are on schedule for December right now because we are finalizing mapping. He's reserving the right to pull any individual exhibits for 1 quarter just to make sure basically that we don't report anything incorrectly for you. What I've seen so far, though, is there's very little other than the neurological stuff that would be impacted by the changes on these forms. Most of this stuff mapped over pretty directly. But yeah, so you should see, I would say, all of the exhibits, and if not, he may pull like 2 for 1 quarter, and then they would return in the next quarter in 2022.
Okay, great. Thank you, John. Okay, the next question's from Sherry. How often do we document hemolysis hypertension? Every review and when patient in hospital, or each individual office visit and multiple times during hospitalization? So really, in reviewing the hemolysis and hypertension, obviously it would be at every follow-up that's scheduled. And if there was a rehospitalization and the patient does seem to have meet hemolysis or hypertension, then if it's an issue, then you would document it there also. As far as multiple times during the hospitalization, I think, if the patient is hospitalized and if they do have a hemolysis event, then you would document it, once it occurred. And that would cover that time span. As far as if the patient had hypertension, hypertension is like a condition. So if it occurs, you would document it. And then especially if they were given treatment for it, then it obviously, would resolve. But yeah, you would do it at the follow-ups, definitely. And then if the patient was hospitalized, and yeah, really anytime you came in contact with the patient, if they had a hemolysis or any adverse event, then you would document it.
Hey, Catherine, I was just looking at the implant form. So on the implant form under the concomitant surgery, yes, there is an option for ECMO insertion. And then underneath there, if you scroll down, there is the option for VV ECMO or VA ECMO.
Okay.
On the implant form.
Okay. So you would be able to document that once, how it was on the initial, when you first initialized the ECMO, but if you did change it out, there would not be a space to document it unless you put it under the other adverse events.
That's exactly right. Yes.
Yeah. Sure. I'll take the next one from Kelly. Can you please share the intent behind reporting minor bleeding type 1 as a type of major bleed? I think really, Kelly, they just wanted to make sure they capture all the bleeding events. And obviously type 1 is not as serious. I mean, we consider all the major adverse events for Intermacs, serious events. I think they just wanted to make sure, I don't think John and I'll probably look at this in a month or so to see how many type 1s we have coded for major bleeding. But I think just to cover all the events, all the bleeding types, like the ones that really aren't that, they're serious and we need them documented in these patients, but it's not like a type 3, 4, obviously 5.
I can take the next question. So if the patient was readmitted and they are started on inotropes or receive IV diuretics, they would not be captured as having late right heart failure if the IV diuretics or inotropes are not maintained for 72 hours. That's correct. So for late right heart failure, it's the hospitalization that occurs greater than 30 days post-implant, which requires IV diuretics or inotropic support for 72 hours. So that's correct. 1 dose of IV diuretic would not qualify as having late right heart failure. That's right. It would not qualify.
And then from Christy, will the new hemolysis and right heart failure AE events be a live download option? Yes, they will be. It does take time to get all the other wonderful apps when we do a version upgrade to everything to get upgraded. I don't know if John and Rama have an update on the live downloads when those will be updated.
Yes, Catherine. So this time we actually streamlined the process. So the live data download should be updated with the changes. There are a few minor things we're working on, but most of the changes should be already in the live data download.
Okay, perfect. Thanks, Rama. And then from Tiandra, she says the option to capture detail on ECMO is on the pre-implant form. Yes, it is on the pre-implant form. So if they do have ECMO prior to the LVAD, then yes, you can document it there and you can document it on the implant form. But I thought your question was like in the middle of the course, if they switch it from VA to VV, you know, like a week after their initiate ECMO. So thank you. And so feel free again, if you have any questions, this is your time to ask any questions for the, on the new version upgrade for the adverse events. I'm just gonna go back.
You have a hand raised. Hey, Catherine, it's Carol. Great job on the webinar today and answering everybody's questions. I see a hand raised and I don't know. I don't think this person, it's R. Bartow.
Okay, Rose, sure.
So I'm gonna unmute Rose
Okay,
and see if she's able to share her question with us.
okay, thanks.
Rose, are you there? It might have just been a erroneous hand raised.
Okay, sure. Okay, well, I have on the webinar posted now, like your resources where you can find everything, and the as Patricia discussed under the appendices, on the Intermacs homepage under the appendices, you'll be able to find the training manual and the FAQ and the data collection forms and everything that I had discussed earlier. But if you haven't looked under the appendices, I encourage everyone to go to the homepage and click under the appendices to see all the training and educational material that we have there.
See, one more question for you, Catherine, from Eva.
Let's see. Hey, Eva. So Eva's asking, would a patient that had the RVAD and LVAD right heart failure is entered at the 1 week, at the 1 month, the RVAD was removed, but still needed IV diuretics, they would have both early and late right heart failure, not the same AE. So they had the BIVAD after they left the OR, so that would be the early acute, and then you're talking about they still needed the IV diuretics. About coding that again as late right heart failure. Patricia, what are your thoughts? They still need the IV diuretics?
I would say yes. I would enter it separately, just to capture that it's, continuing
Still
to go
ongoing.
on. Yeah, still ongoing.
And that might actually be, that's a really good point, Eva. So that's actually something I'll discuss with our task force chair, Dr. Pagani, to see when we have scenarios, because I'm sure we'll have these patients will have many scenarios like that. So thanks for bringing that up. And maybe we can add an ongoing option or think of the best way to capture that. I think I saw another hand raised, but I don't
see it anymore,
I
Catherine.
I don't see it anymore.
It's like ding dong ditch.
Yeah. Well, thank you, everyone. Thank you so much for joining the webinar. Again, if you have any questions, please, you can contact myself or Patricia. and with your questions, especially as you're getting in there and entering these new adverse events. And, you know, as I mentioned, we haven't had updated adverse events in about 7 years. So we're all learning. And so definitely thanks for your time. Be sure and ask us questions when they come up. And again, we will not have a user group webinar at the end of the month, nor at the end of December, but be on the lookout because we'll send out email communication about the dashboard training. And I encourage everyone to take part in the dashboard training, or at least review the YouTube before you utilize it. Before we go, John, did you want to say a word? Because I know Patricia and I've had many questions about like the how the hemolysis and right heart failure events that were triggered are now, the zone events are now showing up as AEs as a result of the mapping, or?
Yeah, so if there's any worry about there being duplicated AEs, or I know we've seen some concern about people that are just seeing those AEs that have appeared on the patient summary. All those they are what were formerly zone conditions that were entered on follow-up forms. If, for instance, like a hypertension, if those blood pressures would have caused that to trigger at like 1 week, 1 month, and 3 months, you would see a few of those that have appeared kind of back to back on your overview. But we've done our due diligence to do all the vetting on that mapping code. Things like hypertension were very straightforward, so I don't think there's really an opportunity for there to be an error there. But we do appreciate like any kind of feedback on this. If any of the users see anything that they question or anything like that, to let us know. And we are, like you mentioned earlier, Catherine, with the bleeding, that this is the first time that we've done any kind of major revision to adverse events in a while. So these are things that we're going to go in and evaluate over the next couple of months to make sure that the users are getting the best out of the changes that have been made.
Yeah, thank you, John. Thank you so much. And again, another big shout out to UAB, the Intermacs Data Warehouse, for all the great work they've done and the new tools that they've provided us. So thank you.
I also wanted to just mention real quick that I've had a couple of emails from you guys about the number of days of intubation. That data field is going to be fixed shortly. I think it wanted you to enter like 2,660, and it will be fixed shortly. So sorry about that.
Yes, thank you. And thanks for your patience with these little kinks we're finding. But thank you so much. Thanks to everyone y'all that took the time to join the webinar today and to ask your questions, and keep asking them. We're happy to answer them. And Carol and Leanne from STS, thank you for joining today.
Thank you.
Great call, Catherine.
Yeah, great job.
Thanks, guys.
Y'all have a
Hope y'all
good
have a great
day.
week.
Yeah, thanks everyone. Have a good day.
Bye, everybody.
Bye.
Thank you.